Good afternoon. Today is March the 12th, 2025, and it is 1:06 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, a committee member may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. We will now receive public communication for the Strategic Planning Committee, Budget and Finance Committee, and Board of Managers meetings. Are there any public comments today?
Yes, we have one chair, Stephanie McDonald, Central Health.
Oh, Stephanie.
I believe she's here in person.
Okay.
Oh,
Okay.
she just walked in.
Hello, Stephanie. Thank you. Yeah, thank you. Okay.
Do I need to read the guidelines?
I know the guidelines, I'm pretty sure.
Perfect. Thank you so much, Stephanie.
Thanks,
Thank you,
Yesenia.
Amanda.
Sorry. I'm going to start with the screen and Edwin's good work. Take it away, Edwin. Is that the way it looks right now? No. Come on. Three 10/2025, Community Care saw their first patients at the Del Valley Health and Wellness Center. I know it's been a long time coming, and my heartfelt gratitude to the Community Care team, to the project team, including our own Central Health folks, Mandy Pletz, who's the Director of Construction and Development, Michael Sloan and Sylvia Kirschling, as well as all the others who have contributed to seeing the first patient Monday. And really a lot of gratitude to our community for keeping the faith and believing in us. And we hope that this becomes an amazing site for health in our community. We went to Popham Elementary. The team went out last week to get families excited about it. We had some show up on Monday without an appointment, got their eligibility appointment done there at the Del Valley Health and Wellness Center. We do look forward to an official grand opening sometime probably later in the summer, and more to come. So thank you so much, and just wanted to share the good news with you all.
Yay.
Well, thank you for that good news in these dark times. So we will now receive public communication for the Strategic Planning Committee. Oh, I'm sorry. Okay. Review and approve the minutes of the January 15th and February 12th, 2025 Strategic Planning Committee meetings. Dr. Martin, Dr. Martin approves
Yeah.
and seconds. Number 2, receive and discuss a presentation on the Central Health Demographics Report. J.P. Eichmiller, Ashley Toth, and Jesse Patton-Levine will be presenting. It should be, yes.
Good afternoon. J.P. Eichmiller. I am the Vice President of Strategy. And it is my privilege and honor today to present to you our 2024 demographic report. This has been a 13-month process to get to this point. We've poured resources and people and brain power in this like we never have before. and we're just very excited to bring this forward and release the report to this board today. Next slide, please. So very quickly, I'm going to go through what's new for this report, and then I'm going to hand it off to my colleagues. Next slide. So this is part of what's new. This team of dedicated staff, this represents a portion of the folks who worked on the report, a few that I'd really like to quickly acknowledge here today. First off, my colleague Ashley Toth. Ashley came to Central Health 5 years ago, and I can say without a doubt that this report would not be here without her work and the dedication, the knowledge she brought to it. A new member of our team this year, Drew Kolarczyk, came on as a project manager and was really the backbone behind keeping this engine running over this course of time. Sitting next to me is Jessie Patton Levine. She's an epidemiologist. Quick story, I was talking about this report to Dr. Jewel Mullen last week, and she said, "That's great, JP, I appreciate this. I really hope you have an epidemiologist presenting this." So we're really happy to have her and her expertise and knowledge here. She's been with us, I think, 9-10 years, even longer. I'd also like to thank Monica and Pat for the executive sponsorship. We met with them early, presented this idea. They challenged us, pushed us to take it further, and we just really appreciate that guidance and leadership. Also, there's some members of the team that couldn't be here today, but they were vital to the success of this. Our data scientist, Connor Favreau, and our data analyst, Matt Richardson. I'd also like to thank Sarita Clark-Leach, our VP of Analytics. She's a colleague and a thought partner, as well as all the various employees throughout Central Health on the communications, analytics, operations team that supported us, as well as some external vendors providing graphic design and photography assistance. So with that said, let's get into it. What's new this time? Well, we have 2 maps here. These maps are displaying the exact same data. The difference is the one on the left is using the old census tracts that we had always used up till now. And the one on the right is using the updated 2020 census tracts. What this means is because of the population growth in Travis County, we now have an additional 60-plus census tracts to analyze. So what that does is just really gives us an ability to focus in on areas, especially geographic areas, with more detail. I'll give you an example here on the next slide. On the left, you will see at the center of that box where it says 2010, that's a census tract just east of Palmer Lane and Dessau Road. Kind of an unincorporated area in between Austin, Maynard, and Pflugerville. On the left, that's using the old census tract, so you can see there's one very large area. On the right, you can see how it's changed now. Since the change, it's now divided into 3, and we can see those different shades of color represents different densities of map enrollees. So you can see now that the very north and the very south tips of that old census tract have different concentrations of poverty than what's going on in the center. So this obviously allows us more targeted, more granular analysis. Next slide. This also gives us additional nuances when we're looking at our what we call our focus areas. And these are the areas that have the highest concentrations of poverty throughout Travis County. This is the same area on the left and the right. This is Runberg, which has the highest concentration by far of poverty of any area that we look at. But you can see now, compared to 2024, we can see there's more nuances. There's areas within this focus area that don't have as high of concentrations of poverty. And using this, these new census tracts, we can do this initial analysis. Next slide, please. In the past, we also had what we consider more contiguous areas, census tracts that were grouped together or they were very large. Because the geography has been cut up so much differently now, we now see actually gaps in between these neighborhoods. We're also seeing, and when we do this, we're also seeing changes in the patterns. In 2020, we had focus areas showing up that are no longer in the reports, such as Pflugerville and Del Valley. And we also have areas such as Manor, Hornsby Bend, and Colony Park, where they used to look much, much larger, but now that we have these new measuring tools, they look much different, and we can really see and focus in on the smaller areas where our patients and low-income residents are residing. Next slide. We've also, our new report, we've got a lot of this, which is photos. Our last two reports, I think our last one had a grand total of 4 pictures in it. We've taken a different approach this year. We really wanted to use pictures of patients. This is Mark, one of our respite patients. Next slide. Potential clients. These are folks waiting to receive services at the Sunrise Church. Next slide. Our staff. We realize Central Health staff is a part of this story that we're all working on together. Next slide. And local landmarks, such as this is Wyden Elementary in Dove Springs. Reed Ames, excuse me. Next slide. Throughout this report as well, we made sure that we had benchmarks with which to measure the data against. In these slides, you'll see in the solid and the bold numbers, that represents the FY23 data around enrollee demographics. And in the, versus the dotted lines telling us where we were in FY21. Next slide. We can look at this in a variety of ways as well. This is showing rates of diabetes going back all the way to 2019. It's showing rates and counts. So now going forward, we will just continue to be able to build upon this knowledge. We can always also look at changes through a geographic lens. This is a map that Ashley built that shows the actual movement of low-income populations through around Travis County and the surrounding counties over a 1-year period. So a little bit different with this report. In the past, we've kind of walked you through the details. We wanted to take a little bit, I think, user-friendly, audience-friendly approach, different this year. These are our top themes. And what we're going to do now is kind of walk you through the key findings that support each of these themes to give you specific examples of how we got here. So with that, I will hand it off to Jessie.
Thank you, JP. Good afternoon. I'm Jessie Patton-Levine. I'm Analytics Manager here with Central Health. And I'll be talking about our first theme here, your background impacts your health. And while this may seem obvious, it is important to consider the context within our enrollees engage with their healthcare. And for this theme, when we refer to background, we specifically are referring to race, sex, language, housing status, and income level, the key demographic factors that we examined in our report. So our data shows clear connections between demographic backgrounds and diagnosis rates, and now we'll examine those relationships. Next slide. Our 2024 demographic report focuses on the impact of poverty and how it's changing in Travis County, viewed through a chronic disease and health equity lens. So this section examines chronic conditions, the chronic condition experience of our enrollees, and evaluates health equity to identify disparities and trends, both in terms of person and place. I will cover the demographic findings here, and Ashley will cover the geographic findings next. Next slide. This chart ranks the 12 chronic conditions by prevalence that we examined in our report. It shows rates as cases per 1,000 people. You'll see that cardiovascular disease tops the list with 227 cases per 1,000 persons, essentially meaning that about 1 in 4 of our enrollees have a cardiovascular disease condition. We did use age-adjusted rates to ensure fair comparisons across demographic groups with regard to age distributions. And this is important because chronic disease occurs more often in older populations, and this standardizes the rates relative to age. Based now on 5 years of chronic disease prevalence data, we found that since 2019, the overall prevalence rates have remained mostly stable and trending slightly downward, with one exception, which is end-stage renal disease, where we see our nephrology direct practice having an impact. Next slide. Chronic conditions are common among our enrolled members. 36% of all enrollees had at least one chronic condition that we look at in this report, and that's about 43,000 people. And they average about 2.5 conditions per person. This prevalence is striking. As you can see, 1 in 4 enrollees have cardiovascular disease. 1 in 5 specifically have high blood pressure. 1 in 8 either have a diabetes diagnosis or even a behavioral health diagnosis. And these figures may likely be underestimates. This highlights the burden of chronic illness within our enrolled population and the need for more proactive chronic disease management strategies and supports. However, we realize that disease experience is not shared equally by everyone, and to see these disparities, we will be taking a look across 2 dimensions, demographics and geography, comparing those rates with our equity index. Next slide, please. So this fun chart is our equity index heat map, which is our bird's eye view of health disparities across our entire enrolled population. So the rows show population subgroups, with the top few rows in green, if you can see it, representing race ethnicity categories, and the remaining below being geographic focus areas in blue. And we do include persons experiencing homelessness as a distinct geographic group for comparisons. The columns on this chart represent chronic conditions, with the far right column showing the overall average value of the equity index. So each cell contains our equity index value, which is a ratio comparing a subgroup's rate to the all enrollee rate. And this single comparison reveals the disparities as follows. So the gold cells represent values that are greater than 1 and indicate higher than expected disease burden. So if you see a value of 1.5, that translates to about 50% more disease than expected. And the darker the color you see, the deeper the disparity. The purple cells, which represent values less than 1, indicate lower than expected disease burden, and here a value of 0.5 means that we're seeing 50% less disease. Note that the disparities between racial and ethnic groups show greater variation than the geographic area groups, suggesting that demographic factors may influence health outcomes more strongly than location, though both matter. Next slide. So this I just want to, you can go back. So this is the same graph with some key rows highlighted in red, and now we can go to the next slide. We'll look at them a little bit more closely. Here we're narrowing down to show some patterns that emerged from this analysis that reveal some disparities. First, we see on the top row that Black enrollees face the heaviest burden among all race ethnicity groups, with a 40% higher overall risk of chronic condition diagnosis. And they have an excess risk in 9 of the 12 conditions that we present here. There are distinct patterns also among our white enrolled population, with a 30% higher overall risk as compared to all enrollees, and they have statistically significant elevations in behavioral health conditions and substance use disorders. Looking geographically, the South Central Austin focus area stands out with a 30% excess of chronic conditions overall, with statistically significant elevations in hypertension and stroke. And those individuals experiencing homelessness among our enrolled population demonstrate particular vulnerability, with a 60% overall excess of chronic condition diagnoses, including significant elevations in behavioral health, substance use disorders, and renal failure. The upcoming slides will explore these patterns in greater detail, but this map just gives us an overview of where our interventions may be most needed. Next slide. So coming to our first key finding, that Black enrollees experience the greatest disparities. Visually, this chart is pretty spiky, and we're looking at rates of disease by race ethnicity. The red bar that's pointed out there with the arrows represents the prevalence rates for our Black enrollees. And again, we found that this group faced the greatest disparities of any race ethnicity group, with an increased risk for 9 out of the 12 conditions, and again, that 40% excess overall. Additionally, Black enrollees are 240% more likely to experience homelessness as compared to the overall population. Even though they are only 6% of our total enrolled population, they make up almost 20% of those individuals experiencing homelessness. And we'll talk about the specific challenges of those unhoused individuals a little later. Next slide. So this is a different graphic to illustrate the breadth and depth of the disparities at the condition level. Here we're looking at a combination of both the prevalence rates from the last slide along with the heat map that we saw earlier. So the result is this list, which is in descending order. You can see the equity index score for each of the 12 chronic conditions. And continuing with the color coding scheme, gold bars represent an increased risk relative to all Central Health enrollees, and the purple bars represent decreased risk. The disparity is listed explicitly on the right-hand side of the graph. So although none of these individual differences showed were statistically significant, there is a pattern that you can see that's viewable in this graph. Conditions such as asthma and substance use disorders, behavioral health conditions, renal failure and heart failure had excess burden among Black enrollees 60% and higher, whereas diabetes, end-stage renal disease, and cancers were less likely to be diagnosed. Next slide. So this is a similar graph, but looking at the results for our white enrolled population. And this is where we'll introduce our second key finding here, that white enrollees experience disparities too. Generally, these disparities were less extreme than what we saw for our Black enrollees, with 2 exceptions. There's a nearly doubling of the likelihood of a diagnosis for behavioral health generally, and a greater increase for the likelihood of substance use disorder diagnoses. And we also see moderate increases in risk for COPD, renal failure, and asthma. Next slide. So now we'll look at this graphic again, but this is for our members experiencing homelessness. This brings us to our third key finding, that the unhoused population is particularly vulnerable and growing. Here we can see increased risk for 7 out of the 12 conditions included in this report, as well as an increase in the risk of diagnosis for, a staggering increase in the risk of diagnosis for substance use disorders and behavioral health. There is more than doubling the risk for renal failure and COPD as well, with moderate increases seen in asthma and heart failure diagnosis rates. Overall, the unhoused had a 60% excess for chronic conditions studied in our report. Next slide, please. So to demonstrate the growth that's happening among this population, here we see that in FY21 we had over 9,000 individuals identified as homeless. A 14% increase occurred between then and our report now, where we're reporting 10,615 individuals. I just want to clarify that, just to put out there a definition for homelessness is defined as lacking a regular nighttime residence or having a primary nighttime residence that is temporary or not designed for sleeping. For Central Health, our definition of unhoused includes both unsheltered individuals and sheltered individuals living in temporary or transitional housing, and that includes locations and facilities like the Austin Transitional Center. So in addition to the increase that we saw in just overall members experiencing homelessness, there has been a rise in the demand for services such as behavioral health and medical respite. Next slide, please. So this is a breakout of both our overall our overall enrolled population and those experiencing homelessness by race ethnicity. So the overall population is in gray and the unhoused population is in yellow. You can see here that no single racial or ethnic group forms a majority of those experiencing homelessness, but we do see significant overrepresentation when compared to all enrollees for several categories, including those identified as other race ethnicity, Black, and white. And even though and this is, even though Latinos are our largest overall group by sheer volume and numbers. Another key description of our homeless population, just to describe them further, is that they are majority male, 74%, 86% preferred English as their language, and 94% were unmarried. Next slide, please. So our unhoused members show unique healthcare utilization patterns, and despite higher medical needs and more chronic conditions on average, only 52% utilize services, nearly 10% lower than our overall population. 2/3 of the encounters occurred in a primary care setting. ED visits represented 12% of total encounters, and this is an increase from what we reported in FY21 by 28%. Hospital and EMS service use remains disproportionately high, and specialty care visits accounted for 14%, which is lower than what we see amongst the overall population. These trends suggest that unhoused individuals still rely on emergency services rather than preventative care, highlighting opportunities to improve access and coordination for this vulnerable group. So now we'll examine our largest demographic group, Latino enrollees. Next slide, please. Latino enrollees are the vast majority of people we serve, representing nearly 3/4 of all members. And that brings us to our fourth key finding, that Latinos and our Spanish-speaking population are healthier overall in comparison to the rest. On average, this population is younger, more likely to use primary care, and less likely to have emergency or inpatient hospital encounters. They're also 2/3 less likely to experience homelessness compared to the rest of the population, even though, again, they make up the majority of our membership. Overall, Latinos have a 10% lower risk of chronic disease compared to the broader population. However, Latinos enrollees still face higher risks for 7 out of the 12 conditions, and particularly we see that for cancers, cardiovascular disease, diabetes, and stage renal disease and hypertension. And so now we'll take a look at that equity index graphic for this population so we can see for ourselves. So next slide, please. So again, here we can see that even though there is increased risk identified by the gold colors in 7 out of the 12 chronic conditions, the increases are modest and much closer to the equity line of 1. The largest disparity that we see are in end-stage renal disease diagnoses. However, there was only a 22% increase here. The second largest disparity is in diabetes with 16% increase. There were fairly large decreases in risk for behavioral health or substance use disorders. And overall, again, Latinos had a 10% lower risk of diagnoses for the chronic conditions studied in this report. Next slide. So I'd like to conclude this section on our key finding 5, which is that chronic conditions may be underdiagnosed in our enrolled population. Despite challenges comparing across data sets, our research uses various local and national benchmarks, which show that locally and nationally chronic condition rates are higher than what we're seeing amongst our enrollees. So what this chart here illustrates is our estimated diagnosis gaps based on the most relevant comparable data available. And I want to emphasize that this is very much an estimate, but given that, it can also be useful. As you can see, what may most be concerning are the likely underdiagnosis of cancers, substance use disorders, stroke, and asthma, where we may be potentially missing more than half our cases. These are precisely the conditions where early intervention can dramatically impact quality of life, outcomes, and costs. So Central Health's mission is to create access for healthcare for those who need it most, and the findings we've shared with you so far are just a bit of what's in our full report. And taken in full, these data highlight where our focus should be as we work together towards health equity in Travis County. So thank you for your time and attention on this section, and I will now turn it over to Ashley to discuss how where you live impacts your health.
Thank you, Jesse. Next slide, please. Right. So in addition to your background impacting your health, a key theme from this demographic report is that where you live in Travis County impacts your health. Next slide, please. Thank you. Today I will be highlighting a few specific examples from the 2024 demographic report that speak to how health and social determinants of health vary across the county. These examples include how excess chronic disease burden among Central Health's enrolled population varies by geography and by housing status, and how the distribution of healthcare and other vital services impacts communities in Travis County. Additionally, we'll look at how the geographic distribution of those in poverty is changing regionally, and I will introduce some of the ways services are growing to meet the needs of the community, which Jesse will expand upon later. Next slide, please. As Jesse mentioned, among Central Health's enrolled population in fiscal year 2023, chronic disease diagnosis varied dramatically, depending on an enrollee's background and demographics. While the differences between geographies for chronic disease prevalence are overall less varied, there are some areas that had an excess burden of disease. One example of this is highlighted by the first green arrow on the left side of this chart. This bar shows that East Central Austin had an excess of behavioral health diagnoses based on what we would expect. In addition to the demographic report looking at differences based on focus area geographies, we also dedicate a section to looking at enrollees who reported experiencing homelessness during the fiscal year. One of the reasons we do so is because unhoused enrollees represent 97% of Central Health's enrolled population that did not have an address that we could map. So here we consider the unhoused population as essentially having their own geography. In doing so, we saw that enrollees experiencing homelessness had the highest rates of diagnosis for asthma, behavioral health, COPD, heart failure, renal failure, and substance use disorders. Next slide, please. The chronic condition prevalence rates we just looked at represented our current year data in the report, but we also looked at historic patterns in the demographic report as well as future projections when it came to poverty within the county. Historically, we've seen the highest concentrations of poverty along the I-35 corridor, and while that remains the case, the trend over the past few years has been a lessening of the highly concentrated pockets of poverty in the center of the county and a gradual dispersion of poverty further out. This has primarily been towards areas in eastern Travis County, but also includes areas such as Oak Hill and western Travis County. Next slide, please. This is one example of the data we looked at that shows the dispersion of poverty. Here we are looking at out of those who were enrolled in Central Health programs and moved within Travis County in recent years, where did they leave and where did they move to? In these maps, each dot represents 10 enrollees that resided in a census tract. In the map to the left, each orange dot represents the areas enrollees left, while in the map to the right, each blue dot represents the areas where enrollees moved to within the county. Here we can see how densely concentrated some of these pockets are on the left, where there are almost solid orange patches. And on the right, the dots aren't as tightly packed together and they have spread further out. So historically, services for those in Travis County have been built to accommodate for where most people lived and therefore where there was the greatest need, and that was in the city of Austin along the I-35 corridor. While we still see the most need in this area, we are beginning to see how a lack of access to nearby resources outside the central corridor is impacting the growing number of those in poverty that are moving to these areas. Next slide, please. We see the effects of the centralization of services and resources in many ways in the report. For example, here on the left side, we have a map of the North Central Austin focus area, which is better known as the Runberg area of Austin. And on the right, there's a map of the Manor focus area. The Runberg focus area has access to 6 nearby primary care clinic locations that are within Central Health's network of providers, more than a dozen affordable housing developments, and almost 2,000 affordable housing units, as well as access to several bus stops and routes. The Manor focus area, on the other hand, has only 1 nearby primary care clinic, no current affordable housing units, or bus stops, but does have access to public rideshare services such as pickup by Cap Metro. And this is indicative of what we see more broadly when we look across the county. This means that low-income individuals that live in areas such as East Central Travis County and Oak Hill will face difficulties accessing resources like healthcare and grocery stores, as well as services specifically aimed at assisting the indigent population, because those resources tend to be centrally located and public transportation is often quite limited in these areas. So, if you are a low-income individual living somewhere like Manor, and you don't have access to a car or reliable transportation, you will likely need to rely on having someone else that can help you travel to access resources, or else you may have no choice but to forego or delay seeking out those services. Next slide, please. The good news is, since the last demographic report, we have seen progress towards expanding many of these services across the county, including in areas that are further away from the central corridor. These maps show the Central Health Provider Network locations in Travis County as of September 2024. Since fiscal year 2013, the Central Health Provider Network has grown by 390%. This growth includes additional contracted providers offering an array of different services, as well as Central Health expanding specialty care offerings and building health and wellness centers in areas like Del Valle and Hornsby Bend. This growth means that every focus area in this report has at least 1 nearby primary care provider location. Next slide, please. Additionally, we have seen an expansion of other resources. In particular, the expansion of public rideshare services has provided a way for those who may not live close enough to a bus route to still have a means of traveling within their neighborhood and a way to get to bus stops and transit hubs. Cap Metro offers one of the biggest public rideshare networks in the county, known as Pickup by Cap Metro. Their current service areas are shown in purple in this map and are overlaid with Cap Metro's current bus routes and stops in green. If you live in one of the service zones, you can use an app to arrange on-demand transit service within the zone for $1.25, which is significantly less than a traditional rideshare would cost. While only 5% of Travis County is included in these service zones, a third of all of the land that makes up the areas, in the focus areas in this report, falls under one of these pickup zones. So this is a great resource to help bridge the gap in access to public transportation for those who are in the areas without nearby access to buses. Since the last demographic report in 2022, there has also been a large increase in the number of affordable housing units in Travis County, to where there are now over 47,000 units in the county and an average of 128 units per square mile in focus areas. There are also a number of recently announced projects that will continue to increase the number of units available within the county. For example, it was announced in November that the Manor focus area that was shown earlier in this presentation is anticipating the development of 324 affordable apartments in the future. I will now turn the presentation back over to Jessie Patton Levine, who will provide more information on how service growth is meeting needs in our area. Thank you.
Next slide. Thank you, Ashley. And you can go to the next slide. So I'll be talking about our third theme, which is service growth is meeting needs. Even with the access challenges in areas outside the central corridor, Central Health continues to work to provide services needed by our enrolled members. So since FY21, our network of healthcare providers has grown by 25% and now includes more than 250 locations in and around Travis County. This provider network offers a diverse array of services and includes everything from small local specialty care and primary care providers to larger health and wellness centers and hospitals. In fiscal year 23, there were over 390,000 total visits among our enrollees, which was an increase from our previous reporting by 22%. From our analysis, we see that enrollees will seek care at nearby provider locations, but often those same group of locations are among the most visited by enrollees across all geographies. And so an example of this is to use Manor as an example, is that, like Ashley said, the CUC Manor Clinic is actually the third most visited site among enrollees in that focus area, but the top provider location is actually CUC North Central. And this pattern is likely due to multiple factors, including awareness of locations, a preference for a provider, possible capacity and appointment availability, differences in services offered, and even the proximity of the location to work, school, or other locations. Top provider locations visited by all enrollees do follow a regional pattern, and we'll show that here on the next slide. So this map shows the top visited provider locations by census tract. And you can see regionally, residents visited the same location the most. So to illustrate this, on the north and northeast side in blue, residents primarily visited CUC North Central, or the dark blue, I should say. For most of the southwest census tracts, those enrollees primarily go to Oak Hill, which you can see there on in that chartreusey green. For South Central and Southeast census tracts, the top provider is either South Austin, which is in pink, or the Central Health, Southeast Health and Wellness Center in that lighter blue color. So again, I just want to call out that people do visit clinics nearby, but they may not be the number 1 or number 2 provider location. Next slide. So to continue this theme, I'm going to talk about service and provider expansion across the county. In addition to an increase in our network providers, Central Health has also expanded the scope of existing contracted services. For example, in partnership with Integral Care, our enrollees have access to psychiatric emergency services, inpatient crisis respite, and some additional behavioral health services previously they did not have access to. We have also expanded service, obviously, with our new direct practice specialty clinics. In October 2023, Central Health opened its first specialty clinic facility with 3 service lines, and we are now in operation at 3 sites at East Austin, Capitol Plaza, and Rosewood, Zaragoza, with over 15 plus service lines now providing increased access to needed specialists and expanded diagnostics and therapies for our members and community. Other spaces where we have also expanded service include the Travis County Jail, where we are working in partnership with law enforcement to provide health care to individuals while incarcerated. Next slide. So in addition to the services I just spoke about, which are available to all enrollees, there are some tailored and integrated care solutions focused specifically on our unhoused members. And those services include Central Health's medical respite program, our Bridge Clinic and Bridge Mobile team, and open availability by network providers such as Community Care Arch and Community Care Connections clinic sites, which provide care on a walk-in basis without the need for a referral. Medical respite launched at the start of fiscal year 23 with 10 contracted beds and wraparound care coordination services provided by Central Health staff. We now have bed capacity of 25 and are growing with our new facility set to open this summer. Medical respite has had over 290 admissions into the program since it began. And this program uniquely offers admissions to patients from all points of care, in contrast to many models that are limited to hospital discharges only. Since June of 2024, the Bridge Clinic at Capitol Plaza has provided comprehensive and immediate acute, chronic, and preventative care for people experiencing homelessness. And in September of 2024, the Bridge program launched an innovative partnership with Austin Travis County EMS, allowing first responders to directly bring eligible patients to the Bridge Clinic site and avoid going to the emergency room or even the county jail. In January of this year, the Bridge Mobile team started operations. Based at our downtown campus, the mobile team and its van can reach current and prospective Central Health patients in shelters, in housing, or directly on the streets. The Bridge Mobile team is here to fill in the gaps for people that are unable to access care or who have had traumatizing experiences in the current system. Current mobile sites include the 8th Street Women's Shelter, Integral Care Therapeutic Diversion Center, and in the near future, the mobile team will be visiting patients transitioning into supportive housing at the Hungry Hill Foundation in East Austin and at Foundation Communities Waterloo Terrace property near the Domain. Next slide. Another area where service growth is meeting needs includes our partnership with Sendero Health Plans, where via the CHAP expansion program, medically complex enrollees can receive comprehensive health insurance coverage through a platinum off-exchange insurance plan. In 2023, 806 individuals were part of that year's CHAP expansion, and more than 90% of these individuals had one or more chronic conditions, averaging 3.5 per person. A major benefit to this program is the access to life-saving transplant and related treatments that are provided to members who would otherwise have not had access to these services. These include liver, kidney, bone marrow, and CAR T-cell therapies. Since 2019, 15 transplant procedures have been performed for CHAP expansion members. This program supports an unaddressed need among our membership population of patients. Just in contrast, over the same period, only 4 regular self-pay members from all of Sendero's other membership required this type of service, transplants specifically. Next slide. So building on the findings we've shared so far, it's important to consider what they mean and how they might shape future opportunities. Next slide. One area, as we mentioned earlier, is the potential underdiagnosis of chronic conditions. So this graph shows the trend in cancer prevalence rates and overall counts over time, as we reported in our current and previous demographic reports. You can see that the rate is around 20 cases per 1,000 members and remains relatively stable across the last 3 reporting years. Next slide. However, when we compare our rate to local and national numbers, we see that the rate's pretty low, suggesting that we may not be capturing the full extent of disease within the population we serve. And for cancer, potentially missing, by our estimate, 70% of expected diagnoses. Now remember, we are identifying disease prevalence based on diagnoses codes found on encounters. So individuals who do not utilize services or may not be receiving screening or diagnostic services are missing from these numbers. Next slide. The implications of underdiagnoses raises issues around access to screening and diagnostic resources, and brings to light possible limited treatment options available to our enrollees. And I'd like to note that cancer is just one example, and that underdiagnoses and the impact of that may be present for other conditions as well. And now I'll pass this to JP.
Thank you, Josie. Next slide. So one of our key findings is somewhat obvious, but we wanted to expand upon and how it's applying here in Travis County. So to find the need in the community, follow the housing. And what we're seeing really kind of percolate is that there are 2 types of housing with high concentrations of poverty. One being low-income multifamily apartments, and the other being manufactured housing communities. This photo is of an apartment complex off of East Riverside in southeast Austin. This is similar to other focus areas, the composition that we see, such as Runberg and Dove Springs. Next slide. This is an aerial photo that Edwin took for us from northeast unincorporated Travis County. It is a manufactured housing community, and all those dots out kind of in the hills is just the housing goes for as far as you can see. These areas are primarily unincorporated. They don't have police services. They lack a lot of municipal services that people living in the cities of the county have access to. We see similar communities to this in areas surrounding Colony Park, as well as Oak Hill. Next slide, please. So what do these very different types of communities have in common? Well, one, they've both got very high enrollment. Southeast Austin, about 1 in 5 of all residents is enrolled in one of our programs. And in Northeast Travis County, it's about 1 in 7. Not only do they have high enrollment, they've had extremely high increases over the last 2 years. Enrollment in Southeast Austin increased by nearly 32%. Northeast Travis County went up 20% since 2021. Next slide, please. And following kind of what Jesse touched on earlier, utilization has gone way up, rebounding, continuing to rebound since the pandemic. This graph shows the top 5 locations of utilization for Central Health enrollees. And you can see at all 5 of those locations, compared to 2 years prior, the number of visits has increased dramatically. Next slide. And another view to think of this is not only are we enrolling more people, but more of those people we're enrolling are actually going in and getting services than they did 2 years ago. We've seen a 6% increase in utilization. Next slide. So all this is to say, this data is intended to be a strategic planning document to support data-driven decisions throughout our organization. It is not prescriptive, but is more of a tool for our planning, operations teams, and clinical teams to use. Planning for facilities, planning for services, as well as targeting intervention for at-risk groups, as we mentioned earlier. Black enrollees, white enrollees, our unhoused populations, and those we have potentially not diagnosed at all. Next slide, please. So next steps for this report, the first 2 are going to be happening immediately at the end of this presentation. We're going to be sending out a press release. We are also going to be posting the digital English online edition. We will be participating in supporting a series of community conversations going on in the various precincts throughout Travis County. And we are already in the development of the Spanish translation of this report.
JP, just before we open up, I just wanted to take a moment to share just how tremendously impactful this is. I want to compliment you, Jesse, Ashley, and the whole team for this incredible work. In fact, it was just as I was listening, we were texting as an executive team, we might make this required viewing for all of our staff potentially, because it speaks to our why. It's so important. And I really appreciate the sort of focused, user-friendly presentation. Actually, just building on that, and maybe Chris, I'll invite you to go with me. I'm going to take just a couple slides out of order to underline some of the really critical insights you shared, because the challenge for us is to connect this incredible work to the strategic planning process. So, Chris, I'd like to go back to slide 32. That's this one for managers. I call this the iceberg slide.
What do you call it?
It's 32, but I'm calling this the iceberg slide.
Okay.
So I drew a little iceberg. I'm not an artist, but that's my little iceberg up there. This is the estimated size of the ice under the water. Mm-hmm. If you look at the bottom, cancer we think is 71% underdiagnosed amongst our enrollees. We find 3 out of 10 expected cancers in our population. Human beings in Travis County have DNA the same way they have DNA outside Travis County. The cancer is there. We're just not finding it. So that's slide number 1. If we can go to slide 49. Sorry, Chris. That's this one. This is the drill down on cancer. So I drew an iceberg with an even deeper amount of ice below the water. Just to transit this slide, we found 18.6 out of 1,000. Elsewhere in Travis County, this is now looking at all pairs, we find 65 out of 1,000. And across the country, we expect 97 out of 1,000. So you look at the 18.6 versus 97, and you could argue that even the 97 might be iceberg. You know, there's still some ice under the water there, but we have a huge amount of ice under the water, And goodness knows, finding cancer early makes a huge difference for the outcome. So that's slide number 2. That's the iceberg slide number 2. Chris, we go 39. Please, this slide. If you look at the spread of the network, we really are beginning to provide some of the key access. Those blue crosses represent primary care access, for example. You really do see broader geographic utilization there, which is very good. And then if you go to slide 54, Chris, this is the inverse of the iceberg slide. It's not big enough yet, but this is the one about utilization is up, way up, right? So that's good, right? That we're actually seeing a lot more people, even over a 2 fiscal year period. These are large increases. We have more work to do, but we're getting there. And I think the strategic plan, the healthcare equity planning effort, as it gets rolling, is helpful. Next slide, slide 37. Sorry, Chris. Again, this is out of order, but this is the gradual dispersion of poverty slide. It's getting a little more into the weeds, but we've been asking this question. Manager Jones, you've been asking this question. Are we seeing dilution of poverty, meaning that folks are staying in place, but there's more folks who have more means coming in, so there's just a smaller ratio? Or are we seeing dispersion of poverty? And we might be seeing both, but we're definitely also seeing dispersion. So folks are moving away from the corridor further out, east and west, especially southwest. So the population is dispersing. This answers that question. I'm not saying they're not diluting also, but there's also dispersion, meaningful dispersion, which this is a critical insight that we've been waiting to get data around. And final slide is slide 43, which is the point that people travel to their preferred site. Folks are going to that north central clinic from all across the northern half of our county. They just don't want to cross the river because I-35 is so painful. Yes. But, people will go to their preferred site and, to get, it's not easy to go across 71. So folks in Southwest are still going to Oak Hill, but Southeast serves most of the Southeast. But we have a fair number of folks now moving into that Southwest quadrant. Our geography is shifting. And of course, there are folks who are outside this county boundary who will find their way to the care that they need. And so just making some of these are key insights that are going to be inputs into our planning. So just want to underline those few things that are coming out. And I just want to, again, compliment the team. This is tremendous work, and baton received. Let's see if we can figure out a way to align our plans to respond to these insights. Thank you.
Thank you. And I think Cynthia had a question first.
Lisa was first, and
Lisa.
then I did, and then Dr. Martin.
Okay.
And then me after that.
Okay.
Oh, wait, Shannon can go first. No, you can go first.
Okay, I'll make it quick. All right, well, thank you very much. This is very good data. It's obviously nice to be able to see it in picture form, so to speak. That being said, this is, I guess, more of a question for Dr. Lee and his team. How will this information be shared with community care? Because obviously a lot of this integrates the facilities that they use, et cetera. I'd be interested in learning that.
Fully, and
But
vice
how?
versa. Hopefully, with alignment, this will be viewed by all of our staff, all Central Health staff, including community care staff. Similarly, there's a community health needs assessment that CUC has done, and they're doing very interesting analyses that are different but complementary to what we've done. So we want to put that all together. And Sendero's data are interesting as well. We want to try and put all of these data together to understand what's happening so that we can fold that into our joint strategic planning.
If I could just take it one step further in terms of what you just offered as a response. Perhaps if it's appropriate and within the context of what we're going to be doing down the road in the future with community care, as in a retreat with them, perhaps this is something that you can incorporate into a presentation or make this data available to them.
We will certainly make it immediately available. And then I think if we do our jobs well, and I'm not going to overpromise here, but I would love to see a place where we evolve in a direction where this strategic planning cycle that we're rolling into as we look to the next year's budget begins with asking, where is the need? What problem are we trying to solve based on the data, by condition, by payer, by demographic, by location, and so on. And then we build plans behind specific data-driven targets of the gap we want to close in the coming fiscal year. So I'm not sure we can get all the way this year, but that's the intent, and this gets us one or two significant steps up the rung of the ladder, so thank you.
So Dr. Lee, I think we can begin by sharing this presentation with the CUC board.
Absolutely.
And then, of course, as you requested, Manager May, we can think about where in the process of our meeting with the CUC board it might be appropriate to share. But don't wait for that. Let's send it over to them.
100%.
Does that make sense? We can-
Absolutely, yes, and we're in
And I'm talking
open
about the
session.
board as well as the executive team.
Okay, we will, yeah,
Okay.
for sure, thank you.
Okay, we're just going to go around the room since everybody had questions. So, Manager Jones.
First of all, I'd like to thank you all for this. This is extremely helpful. You can remember back in the days in public health, we did something similar to this in terms of looking at data, and we're talking 15 years ago. What this is basically manifesting is that over these many years, the maps that you see where the dispersion has occurred, it has now occurred. This was projected 10, 15 years ago, it has occurred. So I'd like to compliment you on that, and I think it gives us some directions in terms of where we want to go. I have 1,000 questions, but we don't have time, so I'll just ask one particular one. Could you go to the map where utilization by district is? I think it's 49. Is it 29?
Page 29, 52.6% of unhoused utilized.
No, that one, yeah, thank you. I would like to highlight that the northeast quadrant there, there is only, if I'm correct, one facility in that whole geographic district, which means the city of Manor, city of Pflugerville, city of New Sweden, which is not big, but it's still a representative area. All of the folks literally drive across town because it's the greatest distance geographically in terms of Travis County, the largest section of it. So I think that also lets us know that there are some immediate types of things we need to look at because of the disparity that we have existing among those. Not that the other ones are not, but if you live in Manor, you have to drive, as it says in most cases, to Breaker Lane, or Breaker Lane, I think is the northeast one. That's a long drive, it's a long bus route and the like. And when you overlay the data, what you'll see is this area also has large numbers of disparity. So thanks again very much. This is a great, I think we might want to, after we do the meeting with the board, maybe conduct some kind of a town hall meeting for the community to see what we're talking about as well, so.
Especially when I know government affairs is not here, are they in the room? Oops, sorry. Is government affairs in the room right now? Perilous group?
Yeah.
Okay, great. When we do the town hall meeting in,
The 4 precincts.
in the 4th precinct, which is my precinct as well, given that where the dynamics are on here, this would be wonderful to include as part of how you do that meeting.
That's exactly the plan. That's what we did last week as well. So using the demographic report per precinct.
Excellent, thank you.
see it at last week's meeting.
So it was on the,
I was there, I didn't see it.
one-pager, and it was
That's how we
also,
started it.
it was on the one-pager, and it was also, shared by Pat. However, that was from the 2022 demographic report, because this hadn't been published. But
Okay.
now that we have this one, we'll
Okay.
include
Yeah.
information from this one in the future community conversation.
That'd be great.
Yeah.
Yes, ma'am. Chair.
I will only ask one. I have several questions. I'm going to give you one question as a placeholder, not to ask now. I'd like to understand better how we came up with the equity, or how you guys came up with the equity index. It appears to me, if I heard you right, it was a comparison of our OHM enrollees relative to each other. And I'm curious about equity in comparison to the rest of the population. because of the built-in inequities between low-income people and the rest of the population. If we're just comparing low income to low income, it's useful. I'm not saying it's not. It's just not giving us the full picture in terms of equity. So I'd like to talk about that more. And then related to that, I'd like to understand where we're at in terms of setting our targets for our equity dashboard. And yes, I know about that one. I'm talking about the other equity index. I know we did, at least for one thing, we did a comparison, which is great.
We have
So-
this condition by condition. It's the idea to get that slice
Yeah, that's
external.
that's
Yeah,
good.
Yeah.
I just want to understand,
Yeah.
I just want to understand that's a great chart. I mean, it's very helpful for us to understand the relative relationship within our population, but I'd also like to understand the relationship to the greater population. So now, just for my question, is how, and how are we going, what is the thinking about how to use this demographic report for our upcoming budget cycle? So for example, how will this report be used to guide the projects that are in our equity plan in this coming year, the key projects in our equity plan in this coming year, as well as the rest of the years that we're projecting? And so, as well as not only just for our, for Central Health Services, but our opportunities to collaborate with CUC, Integral Care, and others in the community. So, can you talk with me for just a minute about how this report will be used to guide our budget process?
Yeah. So, so that was a very complicated one question, but I'll do my best.
let me.
No, I got it. I'm just joking.
It's one question.
I'm joking.
And given the time, it's
Yeah.
one question. That's it.
How do we incorporate
And the
this
question is,
plan?
how are we going to
Yeah.
incorporate this data
Yes.
into our?
Apologies for my levity there.
Well, I'm just looking at the time. So
Yes,
I'm
no,
trying to-
absolutely. I think now that we have this published in hand, we need to digest it. We need to digest it together, as Manager May was saying. As you are aware, Trick Kitchen, as we will be discussing together, we are going to be planning side by side with our CUC colleagues in much greater depth than we have in previous years. So we're going to fold this in to our assessment of needs. I made an emphasis on the iceberg slide. And the inverse iceberg slide intentionally, because we have not had that view before, and that is the sort of urging of the teams. Don't just look at the enrollee population, look at the entire population and what we expect to find and don't find. And so let's make some plans. Our Center Health Strategic Plan anticipates, the data that we've seen, as you pointed out, Manager Jones, for 10, 15 years. And I think we are building utilization in the key areas, so a lot of it is right on target, but the iceberg was not something that we explicitly saw and built for. So I want to challenge our teams to begin to think about a plan for that, and maybe specifically for cancer. And so we don't have those plans in place yet, but we want to think about that. And so I don't have an answer as to what the end state plan will be, but we're going to take these inputs together and really try and come up with targeting toward those needs.
Okay, yeah, I really just had a process question.
Okay.
Because we're going to be taking up the budget, in the next few months, soon. And so I'll just say it this way. I would like to see, as we understand the dollars in our budget that tie back to projects, how do those tie back to what we've identified in this? That's what I'm trying to say. Okay, you can go.
Yes, okay, Manager Martin.
Thank you. I'd like to reiterate, that was really a great study. Thank you. I do have a question, kind of moving, sort of thinking in the future, because Manager Jones and you showed there's been dilution of people away. And I was curious in any way demographically to see dilution out of county, as they don't have support services that we do, and they'll be accessing our clinic system. I don't know if that's something that can be tracked demographically somehow or not.
So Ashley did do a analysis of the surrounding counties, obviously not as in-depth as what we did focusing on Travis County, but could you speak to a little bit of that?
So in the report, we do look at the broader region, so the 7-county area, including the 6 surrounding counties, and we look at how poverty has changed in the surrounding counties, and we break that down by census tract. We also look at where movement has occurred and break down movement within the surrounding counties for those in poverty. Unfortunately, we don't have as detailed information that we can pull on for outside counties to break that down by further demographics, but we do try to look at sort of where movement and growth is occurring for those experiencing poverty outside of Travis County as well.
Manager Valadez.
Just a quick update to you. I used to go to some of those meetings for the state regional area, and they would give you the demographic information breakdown on changes, and you can actually talk to the different representatives from the counties who are supposed to be responsible for gathering that data and sending it to the state. And the only problem they ever had was getting responses out of Fayette County. But they seem not to ever want to respond about poverty. But anyway, the state data, look at the state data, especially since we're in a region. I like this. My big concern has been historically that we don't get numbers. So when I see that we have, yes, we have, I don't even see Latino in here, but I know that we're the majority population. I want to see that also, but I want to see the numbers. If I'm going to target, these are our most important populations, well, if I'm going to create an initiative to affect the most impactful type programs that I'm recommending, I want to be able to say 100,000 people in this population will be impacted by this amount, by this program, by this money, this initiative. If it's 5 people out of this population that are going to be impacted by this big project, I want to know that, because that translates to targeted, I guess, provision of services to the diagnosis in the demographic population. In addition, I would like to know whether or not the people who did this study, y'all did the study, was it personal, face-to-face, phone call, computer? I mean, how was that data collected?
Yeah.
Just curious.
Yeah, so for this question is related to the chronic disease prevalence data specifically.
Well, and the reason when you say chronic disease, when we made our change in how we were going to accept people in the MAP program, we changed the requirement, the eligibility requirement for at least expanding it to 2+ chronic illnesses. And I don't see 2+ chronic illnesses, or I see 3+, but I see 1+, and I'm sure all of it's important, but I was just curious.
Yeah, so the data used in this, in terms of the actual data for our enrolled population, it starts with eligibility. So this includes anyone enrolled in MAP or MAP Basic during the year. The way that we are identifying people in a disease cohort is we're looking at diagnoses codes present within our data, which comes from various utilization sets, including claims and invoices for services received through MAP. It comes through our hospital data sources, which we receive in partnership with Seton and St. David's. And so, and to ensure that we're not maybe missing someone who's enrolled this year who may not have seen or sought services, we do a 3-year look back and kind of putting the assumption that, these are chronic conditions. And so if they were diagnosed last year, more than likely they are still active.
So we're looking at the computer, your billings, basically. You're looking at your computer data?
Yes.
Okay, that says a lot, yeah.
It's hundreds of thousands.
No, I get it. No, I understand that. But I do like that. I do want to see numbers.
Yes, and at the
And
conclusion.
I have asked that before.
At the
Almost
conclusion
every
of this, we're going to hand out the paper reports, and it's 106 pages. There's lots of the numbers I think you're going to want to dig into in there.
Yeah, I think that would be very important. And to put that online for people to see in English and in Spanish and maybe other languages at some point. Okay, and I like the idea of having the town hall and making sure that this data is available to the people who attend the community conversations in each of the precincts. Thank you, I appreciate it.
Madam Chair,
I have other questions, but I'll send them to you.
Thank you.
Yes, Manager Johnson.
just a quick question related to what Manager Martin alluded to. Do we have any idea of those cities who are in the city of, in the county of Travis, but actually there are parts of other counties, and come to mind particularly Elgin.
Yeah.
City of Elgin has a large population
Travis County.
of working individuals that are in Travis County, but it's part of the city of Elgin. Do we see those clients if they are citizens of Travis County? And so that's something you might want to just consider. And the same thing when you look around the other borders of the southern parts of the county, down by Shady Hollow and out west on a couple of other. So thanks very much.
I'm sorry, last thing, with respect to the housing, because you do have to follow housing at some point in time, especially for poverty populations who switch residences every 6 months. Look to see what the future affordable housing, where are they gonna be targeted? That helps us. On a map.
Manager Mawani, you wanna?
Manager Matwani, did you have any questions?
I have two comments. One, is that the derivative insights from this report are amazing, and it's really nice. I think a lot of that is a function, of course, of just having time on our side now, since we've begun to collect substantial data. And so moving along the timeline will obviously increase the value of our insights. But it's just dimensionalized on many more levels than the dimension of time. So wanted to shout out in that way. It's very, very much more sophisticated and robust than we've seen before. So kudos and thanks. And secondly, just kind of a variation on the theme of important notions, numbers, or values to be tracked to inform how we make our investments and how we report our successes. Noting that the Bridge Clinic and the partnership with EMS kind of explicitly diverts theoretically visits from the ED. It would be nice to start tracking that metric, not just the Bridge Clinic, but even at a higher level, attempting to get a sense of where we are averting usage or sort of unforced usage of the emergency department. And what kind of cost savings that may or may not be bringing. Cost savings, there are other improved outcomes that may or may not be bringing to the healthcare district. So, thanks.
Thank you so much. It's a wonderful report. Really enjoyed it, and we'll be looking into it further. Thank you.
Thank you.
Thank you.
And so no motion is needed for this item.
Just follow up. When would we be seeing the numbers? I want to know when we would see the numbers information added to this.
There's a lot in here.
Okay, I'll look at it. Thank you, Eddie.
All right, so now we're going to receive and discuss an introduction of fiscal year 2026 strategic priorities and budget development process and calendar. Dr. Pat Lee and Monica Crowley will be presenting.
Right, so I have the privilege just teeing us up, and then I will turn over to Monica for the main show. But what I want to share is this year we want to learn from last year, by which I mean that we tried some things last year, like starting with driving forces, and then confirming with your input and listening to the community. Then we talked about priority actions against those driving forces. And we got input from the board, and then we built the budget with that. So that arc from last year, the feedback we received from, I think, all of the managers, that was well received. So we're going to do that again this year. So you'll see that in there. The second key thing I'll share this year is that we are planning together with community care. What that means is that when the budget comes to our board for that final approval before going to the county, it will be the consolidated budget of Central Health and Community Care together. And then backing into all of that, there will be a series of aligned meetings with our board, CUC executives with CUC's board and the CH and CUC executives together as we integrate the business case planning process. As I'd said this time last year, this is quite a lot of change. It'll probably be bumpy in various ways, but we will learn from the process, and hopefully it will be better than last year, and we'll keep on getting better year over year. In the background of this, we're going to talk at a sort of high level here, but in the background of this, we're also doing something interesting on a management system level, and it links to our previous conversation. We are challenging the teams to start the planning by asking, what is the problem we are trying to solve? What is the need that we are trying to address? On what facts and data are those needs based? And if the intervention is proposed, how do we know that the intervention is likely to be effective? Have we tested that? Have we seen that? What's our basis for predicting what we'll get for what we spend in time and effort, staff time and so on, and resources? So we are going to be using what's called an A3. This is at the heart of the lean thinking method on a single page, a larger page, representing the thinking of what we're trying to solve, what causes the problem, how we interrupt it, and then how we improve. You can think of this like a physician's clinical note. What's the patient saying? What am I noticing in my physical exam and labs? What is my assessment of what's going on? And then what is the plan prioritized to find out what's going on and to intervene? And so we'll be folding that process in again. It'll be new, a little bumpy for us as we work that direction, but ultimately, just like we would expect in clinical care, you want to do a thoughtful clinical assessment of the need and then address your plans in a very focused and targeted way. So those are sort of high-level comments. I'll also add that the strategic planning team is small but mighty, and we're very lucky to have such talented team members carrying quite a lot of complexity here. And I'm honored to hand the mic over to Monica and Anissa to take us through.
Thank you, Pat. And Chair Frenson, I've also brought Anissa Kendall to join me at the table because she is the one who is actually putting all of this together and helping lead that internal business case development process, asking those key questions and the proposals that come out of that Dr. Lee just mentioned. And could we go to the next slide, please? Thank you. So for those of you that remember the strategic priorities and budget development timeline that was developed for 2025, we didn't include it in the timeline, but I do have a copy here that folks could look at, and it.
Can you make copies for us, please?
Of the last year's?
No, this
one.
one.
Oh, of this one, yeah.
Is it in the packet? I didn't see it.
Oh, yeah, this is the updated version.
Oh, I'm looking at the wrong, I got it. Never mind, sorry.
Brianna's going to share an updated version.
Yes, she made copies. So we have an updated version
Okay,
that
great,
Brianna's gonna hand out. But as Dr. Lee said, this version this year includes additional information. If you look at the bottom left-hand corner, this includes all of the community conversations that are teed up by precinct, and also kind of that final feedback community conversation that takes place in August, where we are gathering public input throughout this process. I think this is something that the communications team and external affairs folks have added this year that I think is really important, because we are gathering input much earlier in the process from the community. We also have on the bottom right-hand side all of the Commissioners Court quarterly work sessions that we have scheduled out, as well as some pending sessions that are tentative, that anything on the document that has 3 asterisks next to it, that is something that is a hold that we are putting in place just based upon potential legislation that would happen. And so these are all tented, the things that are marked tentative with the asterisks are things that we may need to schedule, but that we haven't necessarily scheduled now. We included February 1st, because a lot of the work that's going to go in planning the priorities for fiscal year 26 is going to come out of the February 1st Board of Managers retreat and the follow-up visioning sessions that you are conducting as managers today. Yesterday, we presented at the Travis County Commissioners Court our Q2 update, and then if you look, our strategic planning piece goes between now and primarily through the July board meeting, and then we are really in budget season. If you look, we're presenting the budget timeline and demographic report today. We're also, Jeff and his team are presenting the first presentation on the financial risk that you had requested as a Board of Managers at our last managers meeting. And that financial risk presentation will be completed at the February 26th Board of Managers meeting. In April, we are going to present on proposed driving forces. So in addition to the risks that are being identified, we're going to present, and for people that are new to the board, or just as a reminder to y'all, that was the driving forces that we had identified that were going to drive the work that was going to be proposed for the fiscal year 26 strategic priorities and budget development. And then we will go over at the April 23rd Board of Managers meeting, proposed capital improvement plan, as well as we will review the process for Board of Managers recommended emerging priorities at that April 23rd meeting. We are working on scheduling April joint board meeting between the Central Health Board and the Community Care Board for visioning, and I don't know if that was scheduled.
Managers, that's likely going to be April 19th. We're still nailing that down.
Thank you, but more to come on that soon. Then we get into May. We'll have the May 14th Strategic Planning Committee meeting, the May 23rd Board of Member Recommended Emerging Priorities Submission deadline at that May board meeting, which tracks with the process that we used last year. Additional capital projects presented potentially at a May Budget and Finance Committee if that would be needed based on where the legislative session is heading. And then we'll present a progress update on the current fiscal year's strategic priorities that were both in the strategic plan, the 7-year healthcare equity plan, like NISA prepared last year, that showed this is the overall plan, this is what we've completed, this is what's underway this year, this is what's being proposed as part of that strategic plan for next year, as well as any emerging priorities or ongoing priorities from the current year's strategic plan that are in the budget resolution. One of the things that will be continuing is something like the food insecurity work that was part of this year's budget resolution. We have a 2-year initiative in which that food insecurity is being piloted and addressed. We also are looking to schedule additional board members, the second visioning session and follow-up retreat, and potentially a tour at University Health System in San Antonio. We get into June, and we will go over June 11th, that strategic planning, the proposed strategic priorities for fiscal year 26. June 12th, we will have a Thursday update with the Travis County Commissioners Court. That's our Q3. And then we get the official presentation of the financial forecast at Budget and Finance on June 18th. And this is when we start to transition from the strategic planning part of the budget development to the more budget and finance-based part of budget development. will review the board member recommended emerging priorities with the staff recommendations on June 25th at the Board of Managers meeting. And then in July, at the Budget and Finance Committee meeting on July 23rd, we will do our first joint budget presentation that will include the ongoing priorities, including the Central Health board-sponsored recommendations and the Community Cares budget, that this is going to look different than it has in the past. And Jeff and his team and Joy will be doing a joint presentation of the budget on June 23rd. And then we get into August with the approval of the tax rate on August 27th. And then we've gone ahead and scheduled out multiple meetings in September with a special called Board of Managers meeting for Central Health on September 3rd for the budget and tax rate public hearing, Board of Managers budget adoption on September 10th, presentation on September 16th of the board approved fiscal year 26 budget and proposed tax rate at the Commissioners Court, and then adoption of the fiscal year 26 budget and tax rate by the Travis County Commissioners on September 23rd.
Clear as mud, everybody?
Yeah.
Okay, Manager Musaitis.
Thank you. It's a really quick question. I'm not sure if this is the appropriate place to ask this or not, but for the board recommendations, did we ever receive any updates on our previous board recommendations? So I think we would like to know where it is.
Absolutely, and so those updates will come back as in one of the April or May presentations.
Okay, thank you.
Absolutely. Thank you.
Yes, Manager Jones.
I just have three quick questions. On your outline here, you have Central Health Community Conversations, and by Manor, you have Austin Energy out something. I'm not sure what that is.
That is the location, and I am going to turn to Chris or Ted.
Manager Jones, I can speak to that. Originally, the venue was selected as Austin Energy in the previous version of this slide. And so they said, we're not going to hold the community conversation at Austin Energy.
Oh.
That was supposed to be a note rather than a location. It doesn't mean it's outside. It doesn't mean that Austin Energy's out. We're just not holding it at that venue.
No, my question though is that it should be someplace in Manor, in and around Manor.
Yes.
That's where it will be. We don't have a location
Okay,
yet.
okay.
As of
Yeah,
today,
it's just a placeholder, so.
they were still dialing for a venue selection.
Okay, the second question related to May your retreat visioning with tour San Antonio University Health System. Why there?
That's a placeholder that University Health System is, well, one, it is the closest large urban public hospital district to Central Health, and that is a placeholder. It is, a close regional partner that we're thinking it might be the most feasible location for us to schedule our first collaborative visit with. Also, their former CEO, George Hernandez, is, very interested in working with us, and, they have it's a good comparable community
I've
facility.
nothing against this. I just think that we should also look at Harris Health.
Yes.
Because they have a lot of the particular things that community care has doing that we can learn from them and observe how they interact in different ways, not the way we do it, but in terms of working with FQHCs. And the last question is, are we considering, prior to the budget process, hosting a community meeting to discuss the impacts that we have as of that time of the federal and state reductions, so that as we go into this budget cycle talking about tax rates, we're not talking in the blind. And so I'm just wondering if, are we considering doing that, and if we looked at that?
And absolutely, and particularly as the community conversation, well, as federal and state developments continue, those will be added into community conversations that we're having. Are you saying to have an additional community conversation that's more centralized?
I
No,
think
that's
that
not what we're asking,
Okay.
but
Yeah,
go ahead.
I think that what you're doing is fine, but I'm thinking this is a bigger picture than just a community. I'm thinking of a regional or certainly a county-wide where everyone has the opportunity to come together and hear, both political as well as citizens, what we're facing. That's what I'm talking about, something that.
So I know that Ted's team has been working on I'll call it a communication strategy related to what you just asked, and I think he may be presenting to us in a little bit. But you're taking note of what he recommended, I assume. Okay. As well as taking note of the suggestion that we look at Harris Health also. Okay.
Any further questions? Okay, no further questions. So thank you. And no motion is needed for this item. So lastly, we are going to confirm the next Strategic Planning Committee meeting date, time, and location. Managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, April the 9th, 2025 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I am ready to accept a motion for adjournment. Manager Valadez and second is Manager Martin. Thank you.
I'm gonna give a break.
Oh, yeah, okay, I'm sorry. Yes, okay, vote for that, just for the, yeah.
Good afternoon, everyone. Let's take 5 minutes to for anyone who needs to buy a break or anything, and we will reconvene at 2:50.
Yeah, y'all be back because we're on a very tight schedule today. So just take 5 minutes.
Yeah, so 2:50. Thank you.
We have to start the board managers at 4. So in order to get to the CEO evaluation.
How are you, Jen? Good, thank you. Okay, perfect. Good afternoon, everyone. Today is March 12th, 2025, and it is 2:52. Are we all good?
Yeah.
Oh, sorry.
door.
I apologize.
I don't know what that
Technical
was.
issue.
No, that's just a
Today,
reminder.
it
We
is
did that last time.
2:53 p.m. As a
I know, but
quorum
we asked.
of the committee is in attendance, I would like to call to order the meeting of the Central Health's Budget and Finance Committee. As a reminder, do we have any members online?
Is Amin still online?
Okay, so we have Manager Motwani online, and we will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Managers, item number 1, compensation philosophy will not be considered today. Staff will be bringing them back at our consideration at a later date. Did we take citizens communication? Oh, you did? Okay. So moving on to item number Well, before we proceed, I just wanted to wish the public and everyone else happy Ramadan, Ramadan Mubarak. It is the holy month of Ramadan where we fast from dawn to sunset. And to answer the same question I do every single year, not even water. So this is a conception. People think that we can have liquid, so we don't eat or drink throughout the period of time. So it's a sacred time that millions around the world fast. And it's a really purifying experience, but you do not want to be around me the first couple days. I will be a walking zombie without my caffeine. So that's just, moving on to our agenda. Agenda item number 2, receive and discuss and take appropriate action on an overview of legislative and regulatory factors impacting Central Health's financial forecast. We will have several folks presenting, including Jeff Knodel, Monica Crowley, Katie Colborn, Nikki Riley, and Kim Johnson will be presenting. At this time, I announce that the committee is convening in closed session to discuss agenda item 2 under Texas Government Code 551.071, consultation with attorney. So we are moving into closed session. Thank you. Okay. Well, good afternoon. We are back from executive closed session. And it is March 12th, 2025, and it is 3:56 p.m. We discussed agenda item number 2, and there is no motion for that item. And I am happy to take a motion for our final agenda item. And that is.
The next meeting?
Sorry?
Our next meeting, right?
Yes. Yeah, I have to read it out.
Okay.
So, members are, thank you. Managers, our next Central Health.
Oh, your mic.
Our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, March 26, 2025 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. Do I have a motion?
Second.
I have a motion and a second. All approve. Aye. Meeting adjourned. Thank you.
Okay, managers, good evening. Today is March 12th, and it's 3:57. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. We'll now proceed to the regular agenda. Let's see. We're gonna go into closed session, so I'll read that. So we have 2 items. Item number 1 is receive and discuss a presentation regarding a future state central health system organizational chart and high-level integrated system concept. Item number 2 is discuss and take appropriate action on the performance of the Central Health President and CEO, including activities and performance criteria for the upcoming year. So the board is convening in closed session to discuss agenda item 1 under Texas Government Code Section 551.074 Personnel Matters, and under Texas Government Code Section 551.085 Governing Board of Certain Providers of Healthcare Services, and agenda item number 2 under Texas Government Code Section 551.074 Personnel Matters, and under Texas Government Code Section 551.071 Consultation with Attorney. So members, we're going to go into closed session now. Ready? Okay, let's see. It is, again, it's March 12th. The time is 6:36 and we're entering open session. So we're going to close out of this meeting. We determined that we wanted more time to have more discussion. And so we're not going to take any action right now. And so I'm going to take the next item, which is confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is scheduled for Wednesday, March 26th at 4 p.m. at the Central Health headquarters. At this time, I'm ready to accept a motion for adjournment. Second? Okay, all in favor? Okay, so we're adjourned.